Hello, bonjour, hola. It's my pleasure to introduce myself, Vibhavari Naik, consultant anesthesiologist from Basavatarakam Indo-American Cancer Hospital and Research Institute, India. I am also the clinical lead for the WFSA annual theme for this year, and I wish to sincerely thank the WFSA board and council for giving me this opportunity. On behalf of WFSA, I extend a very warm welcome to our distinguished speakers, moderators, and to each one of you joining us from across the different time zones. In these challenging times, with conflict affecting several parts of the world, I would also like to take a moment to wish peace and safety for our colleagues and communities everywhere. Some conversations have the potential to bring in a change and shape the future. And I'm sure that this webinar today, with our illustrious faculty on board, will bring in inspiring conversations. This webinar is dedicated to the annual theme of WFSA for the year 2026, which is anesthesiology along the patient pathway. This theme encourages us to redefine our professional landscape. It urges us to look beyond the operating rooms and embrace a more holistic, patient-centric role across the entire continuum of care. To align with the scope of the theme and understand its nuances, we at WFSA have planned several activities along this year, and this webinar marks the first of them. So now, to officially launch the activities of Annual Theme 2026, I invite President of WFSA, Professor Daniela Filipescu. Professor is a cardiac anesthesiologist, and she's also Professor of Anesthesia and Intensive Care Medicine at the Carol Davila University of Medicine. And she's the Chief of Cardiac Anesthesia and Intensive Care Department at the Emergency Institute of Cardiovascular Diseases, Bucharest, Romania. I now request her to call upon, open the annual theme for this year, as well as to share her insights with us. Over to you, Professor Daniela.
Thank you, Dr. Naik, and hello, everyone. I welcome you all to the inaugural webinar on anesthesiology along the patient pathway, the 2026 WFSA annual theme, which highlights the multiple roles anesthesiologists play across the entire patient healthcare journey, a theme that aligns with the WHO resolution on integrated emergency, critical and operative care for universal health coverage and protection from health emergencies. Anesthesiology is central to emergency, surgical, resuscitative and critical care services, and anesthesiology along the patient pathway describes what the anesthesiologists are doing every day in clinical practice, the many settings in which we deliver care far beyond the operating room, from pre-hospital resuscitation and transport, rehabilitation, general and specialized anesthesia, to perioperative and intensive care, rapid response systems, non-operating room anesthesia, ambulatory services, acute and chronic pain management, palliative care, as well as frontline responders in disasters and pandemics, as leaders in patient safety, advocacy, and personalized medicine. The anesthesiologist's breadth of practice underscores why strong anesthesiology services are not optional additions, but essential infrastructure for safe, effective, and patient-centered health systems. Adopting a patient pathway approach is important as it reinforces the need for anesthesiology to be fully integrated into health system planning and policy at local, national, and global levels. A core priority for WFSA is the creation of equitable healthcare pathways safer and more coordinated care across the patient journey, improve communication and teamwork across specialties, health system resilience and efficiency, as well as a contribution to health emergency prevention, preparedness, and responses strategies. Dear colleagues of the WFSA family, as we move into this year's WFSA annual theme, please join our activities which aim recognizing and cherishing every step anesthesiologists accompany their patient along the healthcare journey, their complex expertise and leadership role, which reflects a unique perspective on both patient care and hospital management. Thank you.
Thank you so much, Professor Daniela, for your valuable thoughts through this message. And now I would like to introduce you to our esteemed moderators for this webinar. Dr. Edwin Lugazia, who's a consultant in cardiothoracic anesthesia and critical care, Muhimbili National Hospital and Muhimbili University of Health and Allied Sciences, Jakaya Kikwete Cardiac Institute, Dar es Salaam, Tanzania. He is also the president of African region of WFSA and the immediate past president of Society of Anesthesiologists, Tanzania. Welcome, Dr. Edwin. And joining with him to moderate this webinar, we have Dr. Suwimon Tangwiwat, who is Associate Professor at the Faculty of Medicine at Siriraj Hospital and Mahidol University, Bangkok, Thailand. She's also the president of Royal College of Anesthesiologists, Thailand, and Secretariat General of the Asia Oceanic Society of Renal Anesthesia and Pain Medicine. Welcome, Dr. Suwimon.
Nice to see all of you.
Good evening. I now hand it over to our moderators to begin the proceedings of this webinar. Over to you, Dr. Edwin.
Thank you so much. Well, it's a pleasure to have you all join this session. As you heard from the president, I think we have a long journey and we all need to be on board. For today's session, we have the following agenda. We are done with the introduction, so I'll take you through the housekeeping. But along the way, we'll have the talks, and the first talk will be from Dr. Caroline, that's anesthesiology on the patient pathway. This will be followed by from Block's pathway, advancing regional anesthesia care. This is from Professor Nabil. Then we have effective use of artificial intelligence in optimizing patient care pathway from Professor James Meier. And lastly, we have doing more with less, effective rehabilitation in resource limited settings. This will be provided by Dr. Vijaya Patil. And then as members, we have a session for question and answers. As for housekeeping, the question and answers should be submitted via the Zoom chat function. So we kindly invite you all to share your questions as early as possible so that the presenters can address them at the end of the day. And then we understand we have different people from different countries and we are comfortable with different languages. So we have the Zoom AI translation feature to be with the subtitles. Kindly activate that in your Zoom window. And of course, this session and subsequent sessions will be valued and we'll get certificates for attendance that can be used for CPD depending on where you are. And these certificates will be ready after 7 days, business days, once we are done with this webinar. And the webinar will be recorded and that will be accessed later on via YouTube. I think the link will be shared to all participants who participated. Having shared let's keep our mics and videos muted so that we give chance for the presenters. Next, Without wasting time, we have a lot of sessions to listen to. A lot of interesting information will be shared with us. Our first speaker is none other than Dr. Caroline Haylock, President-elect WFSA, anesthesiologist, intensivist, and pain specialist. She has been the director of programs in the past WFSA. She has been a representative of the Latin America on the WFSA Council, and a lot of other activities that we might have engaged with her. But for today, she's going to take us through the anesthesiologist along the patient pathway. The time is now. She'll give us on how can we change our attitude from event related to leaders along the pathway and bring up the best that we can provide to the clients. Welcome, Dr. Caroline.
Yes, good morning, everyone, distinguished colleagues from all over the world. I'm Carolina Haylock-Loor, President-elect of the WFSA, and it is an honor to participate in the launch of our annual theme 2026, Anesthesiology Along the Patient Pathway. These are my disclosures, and this is the agenda we will go through this day in this following minutes. So I'll start asking why it is so important to have an annual theme. And as we go through this agenda, you will see that anesthesiology is no longer confined to the operating room. Today, we will look at how our specialty follows the patient across the entire pathway and how we can get involved in WFSA annual theme. So why the annual theme matters? To begin, let me briefly explain why the WFSA annual theme is more than a yearly message. It is a way of focusing our global conversation with our communities. Since 2023, each year, WFSA select an annual theme to focus attention on a key issue affecting anesthesia care and patient outcomes globally. The purpose of the annual theme is not simply to create a slogan for the year. Rather, it is designed to bring together our global community, our committees, member societies, educators, and partners, and to explore a specific topic in greater depth. Through the theme, we aim to simulate education, professional discussion, and development, support advocacy and policy engagement, highlight the value of anesthesiologists within health system. Most importantly, the annual theme connects our professional work with what matters most, improving care and safety for patients everywhere. For 2026, WFSA annual theme, Anesthesiology, the Patient Pathway, this theme reflects an important reality. Anesthesiology is not confined to the operating room. Anesthesiologists contribute across the entire continuum of patient care in preoperative assessment and optimization during surgery and anesthesia, in postoperative recovery and pain management, palliative care, in critical care and emergency medicine, and increasingly in system leadership and patient safety initiatives. The theme invites us to take a broader view of our profession and recognize the many ways anesthesiologists support patients through their healthcare journey. When we talk about anesthesiology along the patient pathway, we are recognizing the wide range of roles that anesthesiologists perform. Our work spans emergency resuscitation, perioperative medicine, intensive care, pain management, and palliative care, health system organization. However, many of these contributions are not always visible to policymakers, health planners, or even sometimes the colleagues in other specialties. The annual theme, therefore, aims to highlight these sometimes unsung roles beyond the operating room and to help the wider health community better understand the breadth of expertise within anesthesiology. Why these skills matter for health system. When we look at these roles together, something important becomes clear. Understanding the full skill set of anesthesiology is not only important professionally, it is also critical from a policy and health system planning perspective. Anesthesiologists possess a rare but very smart combinations of skills: acute clinical decision-making, complex physiological management, team leadership, and patient safety expertise. These capabilities make anesthesiologists central to the functioning of modern health system, particularly where care must be coordinated across emergency, surgical, and critical care services. When health systems recognize and utilize these skills effectively, patients benefit through safer, more coordinated care. Globally, we are seeing increasing policy attention on integrated models of care. The ECO agenda, emergency, critical, and operative care, reflects recognition that patient care should not be organized in silos. Instead, effective systems link emergency care, critical care, and operative care into a coordinated patient pathway. Anesthesiologists are uniquely positioned in this model because our training already spans these domains. As health systems increasingly adopt eco-oriented approaches, anesthesiologists must also take on greater leadership roles. Each anesthesiologist on this call has the potential to be one of those leaders, helping shape integrated, patient-centered healthcare systems. Recognizing this shift, WFSA has been actively engaged in shaping global discussions about acute care system. WFSA is actively working with global partners to ensure that anesthesiology is recognized within emerging health system frameworks. One important platform for this work is our collaboration with the World Health Organization and the Acute Care Action Network, ACAN. Through these initiatives, WFSA is helping to contribute technical expertise, advocate for stronger acute care systems, ensure that anesthesiology skills are recognized in health workforce planning. The goal is to shape the policies and strategies needed to deliver integrated care and ensure patients receive safe and timely treatment across the entire pathway. But the annual theme is not only about policy, it is about engagement across our entire community. So the annual theme is not just a single event. It is a year-long global conversation. This webinar is the first in a series exploring different aspects of anesthesiology along the patient pathway. Across the year, we will publish educational resources in Anesthesia Tutorial of the Week, the ATOTW, and Update in Anesthesia, our journal. We will host additional webinars and discussions, highlight the theme at the World Congress of Anesthesiologists in Morocco, and celebrate it globally on the World Anesthesia Day, October 16th. The question becomes, how can our member societies participate? Now we have Since ever, 149 member societies across 156 countries. Many member societies and subspecialty groups are already planning their own activities. So we strongly encourage the global anesthesiology community to organize your own events, resources, and initiatives. By doing so, we can collectively demonstrate diversity, impact, and value of our profession, and ultimately improve care for patients everywhere. And beyond institutions, each of us can also play a role. With an issue as important as a wide-ranging as this, we want you as individuals can all get involved and share your own expertise and experience to help highlight the importance of anesthesiology beyond just the OR. Register and participate in WFSA educational activities and campaigns linked to the annual theme. Identify opportunities for share your experience and innovation that demonstrate how anesthesiologists contribute across the patient pathway. Promote awareness of the vital role anesthesiologists play in improving patient outcomes throughout the healthcare journey. When you take this message far and wide, please let us know, and we'll reshare and amplify your voice. Finally, we invite you to be part of this global conversation. Together, we can strengthen our specialty and improve patient care worldwide, because every phase influences outcomes. I also invite you to join the World Congress of Anesthesiologists next month through on-demand registration and continue exploring the theme anesthesiology along the patient pathway. I thank you for joining. Reach out anytime. Stay well. Muchas gracias.
Thank you very much, Dr. Carolina, for the nice presentation on anesthesiology along patient pathway. And it's time now. It is my great pleasure to introduce the next speaker, Dr. Nabil Elkassabany from the United States. Dr. Elkassabany is the professor of anesthesiology at the University of Virginia, where he also served as Vice Chair of Clinical Operations and Medical Director of the main operating rooms. We are honored to have him with us today. Dr. Elkassabany, please go ahead.
Good morning, good afternoon, good evening. Thank you. Thank you, everybody, for having me. Thank you to the WFSA, for our moderators, for the leadership of the WFSA, and for all of you who joined this panel virtually. It's really a pleasure to be here and contribute to that panel. So I also like to thank Carolina for setting the stage very well. This is a perfect segue to the talk, that we're about to give. And those of you who don't know me, I'm probably most of my practice is regional anesthesia and acute pain medicine. So this is a perfect segue. So Carolina introduced the concept of the patient pathway and really how can we be involved beyond the operating room. And this is exactly like what we're going to be talking about today. So as mentioned, I work in Charlottesville, Virginia. Charlottesville, Virginia is about 2 hours south of Washington, D.C. It's a small town, about 50,000 people, very cosmopolitan, very college-oriented, a lot of college sports, and very cute little town. If you happen to be in this neighborhood, please just come and join us. I do have no financial disclosure. I have to disclose that AI has been used to generate some of the images in this presentation. So what we're trying to do today, we're going to try to explore the paradigm shift that you just heard about, from thinking about nerve block or regional anesthesia in isolation to think about it as a central piece of a recovery pathway. Also, we're going to identify, and we're going to do that through the lens of a procedure, a given procedure. I think this is going to highlight that concept very well. The procedure that I have chosen to highlight this is total knee arthroplasty. So pretty much we're going to demonstrate the value proposition of regional anesthesia in the context of an ERAS protocol for total knee arthroplasty. And we're going to try to give you a blueprint for your joint arthroplasty program. So the common saying say that if all what you have is a hammer, you see everything is a nail. I honestly think like that pretty much apply for the fact of regional anesthesia. If you just kept thinking about nerve blocks in the sense it's isolated, okay, there's a nerve, I'm going to block that nerve. And for years and years during the evolution of the peripheral nerve block and during the early era of description of the peripheral nerve block, the focus has been on the success of each of the nerve block and the anatomical difference. What happened if I put the needle here? What happened if I move the needle like 1 centimeter to the left, 1 centimeter to the right? If my depth just increased a little bit, if my twitch monitor went from 0.5 to 0.3. So all these are very important tools and they are critical for the success of nerve block. But here we want to think about blocks in a bigger picture, the block itself versus the pathway. So the traditional, where the main focus is the technical success of the block, the anatomical foundation of the block, and it is procedure focused. When I say procedure, I mean the procedure, our own procedure. Yes, that's important. Yes, it is critical. But also think about if we took that a step further and we integrate that into a pathway model where our regional anesthesia is integrated into a multimodal analgesia protocol, where it's going to achieve better functional recovery and it's going to achieve better patient-centered outcome. And this is going to be exactly the call to action that you just heard from Carolina. This is the concept of having nerve blocks as a central piece in a paradigm or a care pathway that is going to involve all aspects of the perioperative journey of our patient. And again, I'm inviting you, the call to action that I invite you today is to think about your needle tip. So we're thinking about the patient pathway, but every time you do a block, really try to think in a broader way. Try to think beyond the needle tip. Why am I doing this block? What am I going to achieve for that patient? So I'm going to pose a question. I'm going to ask, which block are best for total knee arthroplasty in my hospital? So let's dissect that a little bit. So we're saying which blocks to use for total knee arthroplasty. We're going to have a menu, almost a la carte menu for different blocks that we can use. And I'm going to also ask, what do we mean by the word best? Is it best in terms of analgesia? Is it best in terms of motor sparing? Wider coverage for the block? Am I going to do it as a continuous block, single shot? Am I going to use additives? And if you use additives, which additive I'm going to use? And also, I put the phrase in my hospital. What does that mean? That a block in my hospital with the infrastructure and the resources I have can function very differently from a block that each and every one of you is going to place in your own practice setting. Like maybe I have an acute pain service, maybe you don't. Maybe I can follow up like, a continuous catheter, maybe you can't. How can we really cater, within the limitation and the constraints of our practice in our own environment and really put regional anesthesia to work for the betterment of the patient outcomes? In a sense that we want to achieve the optimal analgesic technique, it's always a balance between pain control, mobility, falls, ambulatory, joint arthroplasty on one side, and on the other side, to achieve the pain control and the opioid requirement. So this is going to be no stranger to everybody. We know that the nerve supply of the lower extremity comes from two main plexi. The two big plexi are the lumbar plexus and the sacral plexus, and they're going to supply the knee joint. Okay, so first and foremost, the traditional, conventional femoral nerve block, I think it has been here, forever. It went through the evolution from the paresthesia to the nerve stimulation technique, now to the ultrasound. And we're not going to belabor just talking about the benefit of the femoral nerve block. But we know that the anatomy, and we know it comes from the roots of L234, and it divides into anterior branch and posterior branch. One of them is going to give mainly like motor branches, and the other one is going to give sensory branches as it travels down the leg during its anatomical journey. And you're going to see the different branch that comes out of it. Okay, great. Let's look at some evidence. Well, it has been compared to intrathecal morphine. It has compared to epidural analgesia. And we found that using femoral nerve block is associated with less side effects from each of the other techniques. It also has been compared to other techniques, including local infiltration analgesia. But you have to pay taxes. If you live in the US or you live any other place, I assume that you have to pay taxes. The taxes that you pay is you get quadriceps weakness. What is that going to impact? But increased risk of falls. This is not good for a patient who's having total knee arthroplasty. Let's look our relatively recent guideline from the prospect group from the European Society of Regional Anesthesia. Pretty much the statement is femoral nerve block, despite analgesic effects, it is not recommended because of reduced mobility from muscle weakness, which can preclude rapid recovery. So that's a statement what we have. All right, let's shift gear. Let's look at the other plexus, like the sciatic nerve block. At some point, this is what every patient who having total knee arthroplasty would get. They will get a femoral nerve block and they will get a sciatic nerve block, and patients were very comfortable, and it has great effect. So what is the evidence? Again, we found that when we do a sciatic nerve block and add it to a femoral nerve block or a ductal canal block, actually we did not have an additional clinically relevant or clinically meaningful analgesic benefit. And this is a concept that we also have to focus on. When we look at randomized clinical trials and we look at p-values for different things, we have to realize that the statistical significance is very different from something else like the clinical meaningfulness. But again, looking at the same guidelines, we see that sciatic nerve block is not recommended because probably very similar reasons. So the evolution of nerve block of total knee arthroplasty, whether you can consider it good evolution or bad evolution, it depends which camp that you live in. So we know that femoral and sciatic, the proximal ones, are not recommended. So let's travel down these two plexi. We got to the motor sparing nerve blocks, whether they are what's commonly known as ductal canal block, which pretty much I'm a fan of calling it femoral triangle block, right? And then the IPAC as an alternative to, and even the genicular blocks now, but the IPAC as an alternative to sciatic nerve blocks. So again, we're not going to belabor the anatomical description of something like the femoral triangle block. I think this is all familiar, and we're not going to waste too much time on that, right? But pretty much it goes something like this. When you block the branches of mainly the sensory branches of the femoral nerve, which supply the anterior and the medial side of the knee, in addition to some other branches from the lumbar plexus, probably branches from the obturator, and maybe some of the motor branches as well. So let's look at some evidence when we compare the adductor canal versus femoral nerve block. Is it equivalent or non-inferior? All the blue literature that said they are equivalent, the red ones, they're saying the femoral nerve is better. That's just the summary of this. How about in terms of functional outcomes? You can, if you dive in the literature, you're going to find literature to support that the adductor canal is better or equivalent, or even some literature to tell you that weakness, quadriceps weakness, can also happen with the adductor canal block. Okay, why we're saying that? We're saying that because we know where you do your injection for the femoral triangle block matters. Okay, the different levels that you block along the nerve pathway is going to matter. And now that we learned that from our knowledge of anatomy, from our knowledge of ultrasound, and from the effort that we did to really define what does it mean to do a femoral triangle block. Okay, not only that, but also that we're now learning that some of the nerves live in different compartments, especially if you're talking about something to the nerve 2 vastus medialis. So I have 4 questions to ask here. Is the femoral nerve triangle block, is that a complete block from a efficacy standpoint? And clearly, because of the introduction that we did, it is not. I'm talking about analgesia, I'm talking about efficacy and anatomy, right? I'm not talking about clinical effectiveness. What nerve I'm missing? Yes, you are missing some of the nerves, all right, that you are presenting. And this is clear from the nerve supply of the knee. And also, if you look at what constitutes surgical insult during a procedure like knee arthroplasty, whether the incision that you do for the medial arthrotomy of the knee, whether it's the incision that you do in the anterior part of the skin, and the different incisions or the surgical insult that you inflict while the surgeon is doing the total knee arthroplasty. Another question, does it really need to be complete block? Okay, I know I'm missing some nerves. Does it need to be a complete block? And the answer is no. And this is when we get to think about blocks as a central piece of a pathway or a protocol or an integration. Even if it comes short, let's say it comes at 65% or 60% short, can the 40% be supplemented by other agent, by other modalities of analgesia that constitute the rest of the multimodal agents that's used for multimodal analgesia? Now, when I think about blocks, should my blocks only be protocol driven or should be patient centric? What do I mean by that? We are all talking about shorter stay. We're all talking about trying to get the patient out early, but we know that we encounter patient every day that no matter what you do, they are not going to fulfill these goals. The patient who using chronic opioids, the patient who are using opioid replacement therapy, the patient who are obese and have higher BMI. We know that these patients are not going to be roaming the floor immediately the day after surgery. Maybe in these patients, 100% analgesia is going to be my goal. I want to just use every ounce of analgesia I can offer these patients. So maybe in this patient, I can think outside the box, and rather than being a kind of a protocol driven, think about that protocol as a bigger umbrella under which that we include a lot of patients. And this is another call to action here. When you read your literature and you think about what is the evidence-based practice, think about it as it's really in the intersection, in that Venn diagram between your own clinical expertise and judgment, what does the literature say, and also the patient value and their goals in their recovery. That's another call to action, and I love that slide for that. If you look at the sciatic, it's pretty much very similar story, that we do now the injection. If we put an injection of local anesthetic between the capsule and the popliteal artery, it turns out that you're going to anesthetize the terminal branches that is going to go supply the posterior capsule of the knee in a manner that is going to also be motor sparing, and it may spare you getting the motor block that you get from something like the sciatic nerve block. This is the approach I personally use, but there is multiple approaches to block the IPAC. We're only we have a couple of minutes left, so we're just gonna forward through that. So the evidence for IPAC exists, but now how do we put everything together? How do we put this in almost a comprehensive pathway for recovery of total knee arthroplasty? 14 surgical societies came together a couple of years ago, and they defined what is the guiding principles for acute pain management. This was led by the American Society of Anaesthesiologists. We were privileged to be part of that work. And essentially, as you see, if you look at number 3 here in these 7 guiding principles, to offer multimodal analgesia. And I think this pretty much highlights what Carolina was talking about. If you look at the patient journey from education, from talking to patients about their options, from having a consultant available, both pre-op, intra-op, post-op, and just leading them. And even if you send patient home with some opioids, are you going to leave them alone, or are you going to just give them a prescription or a guideline for how to taper these opioids? So really a very comprehensive pathway that's going to be very encompassing. Think about that you're dissecting the entire journey of that patient into each one of these boxes. Each one of these boxes is a landing spot for a patient. And there is one of the perioperative stakeholders that's going to interact with the patient. This is going to be the stakeholders that you have to galvanize, that you have to get together in order to have a good comprehensive pathway. And guess who is perfectly positioned, to lead this paradigm? It is you. It's the anesthesiologist. This is what we talk about, the patient pathway. And this is how we can really think differently about regional analgesia. And that brings us back to the first slide that we have seen when we think about nerve block as a central piece of that paradigm, when we think about it as central piece of any ERAS pathway. We're not going to belabor this. This is probably very familiar to all of you. Now, this is a protocol that we used to use in our hospital. And you can see even going from the pre-hospital all the way to post-op, like deploying like, the multimodal anesthesia or regional anesthesia. And I'm happy to share like, all these as much as you want with anyone who asks for it. And pretty much this is like, what you want, all right? This is the picture that you want to get. This is one of our patients. This was 11 a.m. after 7:30 start. So this is 2.5 hours later. And you can see that they are roaming the floors. A couple of hours later, they are out of the hospital. Okay, this is like, what is the definition of anesthesiologist providing the care pathway, anesthesiologist leading the entire paradigm of the perioperative journey of patients and really to provide the best service that we can, like, for these patients. I appreciate you. Thank you very much for your attention, and I'm happy to entertain any questions. And I'm going to give it back to our moderators. Thank you.
Thank you so much, Professor Nabil, for taking us through from blocks to pathway. And I think regional blocks illustrate what we can do to the patients from pre-hospital back to the community during rehabilitation. The blocks can showcase what we can do. So let's get out of the theaters. Instead of being one event, people to the whole pathway coverage. And next, I think we have Professor James Meier. Is the head of anesthesia and critical care from Kepler University Hospital. He also chairs the anesthesiology intensive care department of the Jensen's Kepler University in New Orleans, Australia. He's interested in circulation and in oxygenation, patient blood management, artificial intelligence, and data monitoring for improved patient care. Professor Nabil, thank you and welcome for the talk.
So thank you very much for the kind introduction. I hope my screen sharing works, and I will try to give you an introductory talk into artificial intelligence in optimizing patient care pathways in the next round about 15 minutes. So one thing is sure, you cannot stop the hype. It is impossible. If you travel around congresses, if you read in the newspapers, if you watch television, artificial intelligence seems to be everywhere, and this is unstoppable. Even in our field, in anesthesiology, artificial intelligence is gaining interest. You can see here the blue bars are the articles that have been published within the last 20 years about AI and anesthesiology, and the green line is the number of citations. And you see with the last few years, there's an increasing interest in AI in anesthesiology, and one can believe that AI in anesthesiology is really a hot topic and is really talking off about. What are the main things, the main topics that are dealt with in anesthesiology? This is ultrasound. This is regional anesthesia, as we have heard. This is pain management, airway management, but all sorts of things that have to do with circulation, tissue oxygenation, and transfusion. Then there is a clear focus on the depth of anesthesia, EEG and bispectral index. And of course, there is a huge field about medication, closed loop control of anesthesia, neuromuscular blocks, and propofol anesthesia. If we now take a look at the typical patient journey, then one might think that one of the best things to use at the very beginning are large language models, either to find out something about the diagnosis or probably to improve the process of bringing patients to the hospital and bringing patients at the start of the progress. And it's really impressive, I have to say. What is now possible with large language models, you see here the results of a UCMLE style test, which has been done with different large language models. On the x-axis, you see different years, and what started with GPT-Neo in December 2020 and an accuracy of 30% is now an accuracy of about 91% with MedGemini. For such tests, it's important to note that with 65%, you would pass the test. So these large language models for tests have superhuman capabilities. However, if you take a look how they do in really clinical practice, and this is a publication from 1.5 years ago, then you see on the lower part of the slide that for appendicitis, there are quite good results to have a diagnostic only with the description of the patient and analyzing by a large language model. For other points, this is much worse. For example, for cholecystitis or diverticulitis, the results are not half as good as for appendicitis. If you look in which parts of medicine large language models are used, then you can see here that unfortunately for anesthesiology, this is on the right part of the slide, you can see that only 3.8% of all the publications, all the studies deal with large language models in anesthesiology. Most of the time, these large language models are used in internal medicine or in radiology. However, and this you can see in the small depiction, the amount of publications increases steadily in this field. Second step of the patient pathway, if the patient is now at your hospital, can methods for artificial intelligence be used in order to predict the risk for some specific situation? And yes, this works flawlessly. This is a publication which has been done by my own group. We had the opportunity to analyze the data of Western Australian patients, 250,000 of patients that were admitted to the hospital. And as you can see on the left side, with an AUC ROC of 0.935, you can predict whether a patient will survive admitted at the time at the hospital or not. This is really impressive because you still do not know what happened at the hospital. You only know some of the first lab values that you get from the initial investigation, but nothing more, and these models can be used for risk prediction in that field. What to do with that risk? That is another question. Now there are newer models that base on the transformer technology. The transformer technology is used for large language models, and what you can see here is a transformer model that has been used on the Mimic database. The Mimic database is a public database that can be downloaded by everyone. And they predicted many different entities from this Mimic database. And as you can see here, be it hospital mortality, ICU mortality due to sepsis, ICU mortality after 24 hours, and so on and so on. There are a lot of things that nowadays you can predict using these machine learning models. Once again, what to do with that information and how to talk to patients about that, this is another question and can maybe be part of our discussion. Next step is monitoring of the patient, one of the key assets of our field and one of the most important things that we deal as anesthesiologists on a daily clinical basis. And in monitoring also, there are many things that are now developed. If you, for example, want to predict anesthetic depth by a combination of the propofol dose, the remifentanil dose, and HEWH, namely age, gender, weight, and height, then there has been a model developed in the last year, 2025, where they used 2 LSTM blocks, long short-term memory blocks, put the results together and did a prediction of the BIS values. And not to go too much into the details, but knowing which medication you have given, you can calculate the BIS value from that medication. For here you see 2 different examples, and the difference between what has been predicted and what has been measured is not too far off. So with these new methods, even you don't have to measure the EEG to know what the BIS value probably will be like according to the amount of medication you have been applying. What is also very important and what we should talk about is can we predict the deterioration of the myocardial function and the cardiovascular function? And the most famous monitor for this and the most famous parameter for this is the hypotension prediction index. These are the first 2 publications that were very important in that field that clearly showed that with a monitor and with a specific module for measuring blood pressure, it is possible to predict a decline of the mean arterial pressure. Here you see the AOC rocks from the first validation studies. On the upper part, the internal validations. On the lower part, the external validations. And depending on the time, here 5, 10, and 15 minutes, you can clearly see that the AOC rock is really, really high, above 0.9 in any case, and even 0.97 if you want to predict a hypotension within the next 5 minutes. Very impressive results, and we don't have to discuss about that. In the last year, there has been a publication of a meta-analysis that clearly demonstrated that this monitor works. It can predict the duration of the intrahypotensive hypotension, the area under the threshold of a low mean arterial pressure, and the time that you are in this situation. However, it is important to notice that after some time, the first doubts arose, and it became clear that probably there might be a small flaw in the determination of the test and the training data set. And not going too much into details, and a good sample, a non-hypotensive sample, was defined as a sample where the mean arterial blood pressure is always about 75, and so it was easy for the algorithm. If a blood pressure was below 75, it had to be in the other group, and as a consequence, probably the AOC rocks that had been published were higher as they might be in real life. It's important to note that the meta-analysis of the clinical studies are not affected by that, but probably the results of this algorithm are not as good as one might think on the first view. Furthermore, there were now several studies that found out that there is a very good correlation of the hypotension prediction index and the mean arterial blood pressure. And as a consequence, the area under the curve for a mean arterial blood pressure below 72 and an HPI above 85 or 83 is very, very similar. And so probably even you can predict a decline in the mean arterial blood pressure just by measuring the mean arterial blood pressure itself. So the monitor per se works, but also people from my group have shown that only if you use the current mean arterial blood pressure or put this in a model, this is in the quality of prediction for 5, 10, and 15 minutes equally good as using a monitor. So next step, can we use artificial intelligence for the guidance of medications, for the guidance of treatment? And yes, I think we can. This is, in my opinion, the main domain of reinforcement learning. Reinforcement learning is like learning being a mouse in a maze. You want the piece of cheesecake, and you learn this by action and getting the reward by trying over and over again to find the right way. The first to do that in a clinical setting, and they were real pioneers, was the group around Mathieu Komorowski. He tried to find out whether in the treatment of septic shock, it is better to use vasopressors or to use volume. He did this via a reinforcement learning algorithm, which he programmed for a state world and for actions that have been defined as either giving more or less volume. And not going too much into details, what he found out is that an algorithm can predict more precisely whether one of these two entities will be good for a patient, and the clinician policy was mainly based on volume, and the AI policy was more based on vasopressors than the clinician policy, resulting in a higher theoretical mortality for the clinician policy. So this algorithm was superior to what we do. Very different setting, other data set and other idea. Kalimutu et al. Tried to find out whether it's good to give vasopressin in septic shock in an early phase, and they also used the reinforcement learning approach, a little bit more sophisticated, a little bit more more modern, but in the principle, the same idea. And what they found out that if you take a look at the left side, what clinicians do, they very seldomly add vasopressors, whereas the reinforcement algorithm very often uses vasopressors and uses them at a very early time. So also here, I think in the future, we could be probably guided by the means of artificial intelligence, and these methods will be used for sure. However, if we think about what these algorithms mean, then we never should think that validation in a theoretical setting will result in something we can use on daily clinical practice. What you see here on the upper part is the development of a certain drug. And I think in the future, we have to deal with these algorithms like with developing a drug. We will have a lot of algorithms. We will try them in silico. And then in the end, we'll have to try the effect of these algorithms in the real world. And this will be the real challenge in the future, in my opinion. Coming back to the beginning, I said you cannot avoid AI nowadays. But what also has to be pointed out is the fact that not so many algorithms are really approved. What you can see here is from the homepage of the FDA, how many algorithms are approved. I think the numbers are quite small. If you take a look, this was the last update of this page of the FDA. There are 700 algorithms in radiology that have been approved. Only about 100 in cardiovascular and less than 10 in anesthesiology. I put some of the most famous ones at the lower part of the slide, and maybe some of you use one or the other, but the amount of algorithms that is used nowadays is not as high as one might anticipate from what is the importance of AI at congresses. If you take a look at the publications, you have to say that if you talk about technology readiness level, there are, of course, a lot of publications in AI in the last few years, but only a very small amount is more than TRL more 3 or 4. So we are at a very early stage, and not of these algorithms can be used in a broader setting. If we talk about different professions, like, for example, information services in black, in gray, scientific services, in dark gray, education, orange, finance and insurance, then the usage of AI in healthcare is really low. This is, of course, due to security reasons, due to the fact that this is very difficult to adapt, but in comparison to any other fields, this AI is not used as much as one might anticipate. Even if you take the US, which is probably at the forefront of the usage of AI, then you clearly can say that there are some hotspots in the US where AI is used very often, but there are also a lot of cold spots like all over the world, and even in a developed country like the US, not too many people use AI in the hospital on a broader range. We have also to think about the idea that the ones that are the early adopters live in an AI bubble. What you can see here is a number of dots. Each dot represents 3.2 million people. In total, you see 2,500 dots corresponding to 8.1 billion humans. The gray ones never used AI or a large language model ever in their life. Some are free chatbot users, 1.3 billion. Only a very small amount of these people pay, and using AI for programming or producing something is only one of these dots. So we have to be clear about the fact that AI is, of course, promoted everywhere, but probably if you take a look all over the world, not used as much as we might think. And we have to become aware of the fact that in the end, we are physicians. And of course, the inventor of ELISA, the first large, let's say, small language model, Josef Weizenbaum, stated that there is, of course, a difference between man and machine, and that there are certain things and tasks which computers ought not to be made to do, independent whether computers can be made to do them. And I think only relying medicine and specifically anesthesiology on AI without humans and doctors in the loop is not the right way to go. I am aware of the fact that we, of course, often feel small and helpless against these technologies, but it's my strongest belief that we have to understand these algorithms, that we have to drive them, and that anesthesiologists for sure have to deal with that in the future in order to be part of the patient journey, in order to be able to guide the patient journey with AI in order to improve the outcome of the patients. Thank you very much for having me, and thank you very much for listening.
Thank you very much, Dr. Meier, for your nice presentation on about AI in anesthesiology along the patient pathway. And I think I can see the question right now, and please leave your question in the Q&A session, and we will have the Q&A session at the end of this presentation. Now, let me introduce our final speaker, Dr. Vijaya Patil from India. She is professor and head of the Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital in Mumbai. We are honored to have her with us today. Dr. Vijaya, please go ahead.
Thank you, the WFSA team, for giving me this opportunity. And good morning, good afternoon, and good evening to my friends and colleagues from all over the globe. So I have got one disclosure to make, that this presentation that I'm doing is on behalf of my department, because what we have got, what I'm showing you is a activity that is my departmental activity. So if you look at the Globocon report of 2022, it shows that every year we have got almost 20 million new cases of cancer which are diagnosed, which is increasing every yearly, and that shows the global burden of cancer in the country. Next slide, please. Rosa, can I have next slide? Yeah. And if you look at this, the India ranks third in the incidence. The first is China, second is USA, and third is India. And as far as the mortality is concerned, we stand second next to China. That shows the burden of cancer in my country, in India. Next slide. So if we look at the journey of cancer surgeries over last 2 decades or 3 decades, we know that there has been consistently improved outcomes after major cancer surgeries. And that's mainly because of advancement in surgical techniques and good chemotherapy agent. And of course, we have got ERAS pathways, which are now well established, which has helped in improving the outcome. However, if you look at the literature, the post-op complication rates is still high, the tune of 15 to 40%. Out of which, if you look at claving window 3 and 4, which has more serious complications, around 8 to 10%. And these complications have significant impact in terms of increasing the length of hospital stay, which increases the cost of treatment. And also the studies have shown that because of these post-op complications, it prevents the timely treatment with the adjuvant therapy, which decreases the 5-year survival rate. And a study looking at the lung cancers has shown that 15 to 20% of the patients decrease in the 5-year survival rate. Next slide. So what are the factors responsible when we talk about the post-operative complications? So we have got patient factors like age and gender, nutritional status, patients either smokers or alcoholics, the frailty or the physical inactivity and comorbidities. We have got tumor factors like where's the location, what is the pathology, and what is the staging, because certain cancers are more aggressive as compared to others. And then they've got surgical factors like what is the approach, what is the operative time, and of course the blood loss. Next, Rosa. And if you look at all these factors, not every factor is modifiable, but there are certain factors, especially the patient-related factors, which are modifiable. And what we are trying to do through the prehabilitation is to have these modifiable factors. If we can get the patient in the optimum condition, we can improve the patient's outcome by decreasing the post-operative complications. So what is prehabilitation? If we look at this, we know that the surgery decreases the patient's, it is a major stressor for the patient, which decreases the patient in general condition. So if the patient is, whatever the patient's condition before the surgery, After the surgery, there is a significant drop in patient's condition. And then the patient, if there is no postoperative complication, as you can see in the A graph, the patient will come back to above the line of dependency and will become independent sooner. However, if that patient develops a complication, there are chances that this patient will become chronically debilitated and may not become independent for the long period of the time, as can be seen by the B graph. So what is the purpose of doing rehabilitation is the improving patient's condition, the functional status before the surgery, and so that the patient can withstand the stress of the surgery better and can return to his baseline condition at earliest. And even if these patients develop any complications, they do come about the line of dependency and can have the independent life or the independent lifestyle earlier as possible. Next slide. So if we look at the what is advocated, that if we look at these patients, the patients who are going for the surgery, there has to be a universal approach for every patient, where the patients should be screened for evidence of malnutrition and physical inactivity. And if the patients are good nutrition wise and the physical wise, these patients should be asked to improve on their diet, given the health advocacy about having increased protein intake, and they should also be advised to increase their daily activities to get into the better condition. However, if the patients you find on screening that they have got some risk factors like nutritional deficiencies or malnutrition, or these patients do not have good physical activities, they should be asked to do it with the targeted, they should be given some targets and they should be made to do these things in order to increase their functional capacity. However, those patients who are really very, very poor, these patients will require the specialist reference and they should be prescribed supplementation if the oral route is not available in terms of intravenous nutrition, and they should be advocated under supervision, the high intensity training in order to improve their preoperative condition. Next slide. Rosa, next slide, please. So now I'll come to our story, how we started in the Tata Memorial Hospital. So our hospital in India is in Mumbai, which is a functional, which is it's a major city in India. And this is Tata Memorial Hospital, the tertiary care cancer hospital, and we treat large number of major cancer surgeries to the tune of approximately 8,500 cases per year. The topper is head and neck cancer, because we know that India, we have got a large burden of head and neck cancer because of certain habits, mainly tobacco use, followed by GI cancers and the breast and so on. In our institute, we take pride in having the practice of the evidence-based medicine, and we try to incorporate the recent guidelines and protocol in our clinical practice. Rosa, next. So how it all started in TMH, how did we move on to the rehabilitation program? So we have got the large operative load of cancer esophagus and cancer lungs. It's around 150 cases each year of each of these cancers per year we treat. And there are another additional 100 of complex mediastinal masses and chest wall excisions. Because smoking is one of the risk factor for the CA esophagus and CA lungs, these patients were obviously having major comorbidities. They were getting the delay in getting the anesthesia fitness. There were multiple references which were asked for, and there was poor communication across the different departments. Patients kept on moving back and forth between the departments, which led to the delay in surgery. Next. So our lead thoracic surgeon came up with proposal in 2014 to our department. So we have got a concept of disease management group and joint clinic. So every patient who comes to the hospital, the disease management group, which consists of surgeons, oncologists, radiotherapists, radiologists, and pathologists, they will combine, sit together, make a plan, and then the final plan will be made in the joint clinic. Now, he came out with the proposal saying that only anesthetist is the specialty which is not represented in that. Can we have a high-risk joint clinic between surgeons and anesthetists, where we can thrash out the issues so that we can get earlier fitness for the patients, and the patients' back and forth movement will decrease. So we started this on an experimental basis in 2014, where we had thoracic surgeons, senior anesthetists, intensivists, pulmonary physicians, and then senior surgical residents and senior anesthesia residents together. And the patients would be referred either from the thoracic surgeon initially, and then we also started getting the patients from our pre-anesthesia clinic when the consultant over there felt that this patient is too high risk and it needs to have more optimization done. The patient and his or her caregiver would be called in that meeting, where the patient will be assessed and the plan will be made or the issues will be trashed. And this place initially we started in our own departmental office. Next slide. So these patients were referred based on the surgeon's judgment as high risk, which consisted mainly the patients with uncontrolled or multiple comorbidities, frailty and poor performance status, high cardiopulmonary risk, including poor predicted postoperative pulmonary function, and the patients undergoing complex surgery like large mediastinal masses, vascular involvement, vascular reconstruction, extrapleural pneumonectomies, expecting major blood loss. Like the cases were evaluated jointly in the group that had discussed. All concerns were addressed, and then optimization was planned, in which we looked at the nutrition, anemia correction, the physiotherapy, and the respiratory therapy, patients' comorbidities optimization, and then if any additional referrals were done, was decided in that clinic. The patient and the family were extensively counseled, and they were given the options and explained about the risk what the patient will go through. Next. So now this is how I'll show you. This is our high-risk JC decisions in our thoracic DMG, how we looked at it. So the period that we looked at, we saw that there were 217 patients which were looked at this, were seen in our this high-risk JC clinic, out of which 184 proceeded with the surgery, or 173 were as per the surgeon's original plan. And the plan was modified in 11 patients after we discussed all the risk. The surgery was, non-surgical options were given because we thought the surgery was too high risk and patient would not withstand it. The 27 patients, the plan was changed and non-surgical options were done, and some patients were lost to follow-up. So this is how our high-risk JC, when we looked at the patients, our treatment plan changed. Next. Now the success of, next slide. So the success of this we realized within a year when there was demand from other specialties for similar service, like our GI surgeons approached us first, followed by the Uro and Gynae services, head and neck services, because they realized the way the processes were streamlined, the way patients got faster fitness from the anesthesia clinic, and the way the post-op outcome changed. And that's how when we decided in 2015, we created special separate interest groups in the department. Like those consultants were more interested in thoracic anesthesia, GI anesthesia, urology and gynae anesthesia, head and neck and breast. And we started our second HRJC clinic for the GI DMG in 2015, which included all 3 GI services. We used a similar model, and each specialty had around 1 to 2 HRJCs per week based on what was the patient load. Next. Now, obviously, when this we were doing, we did not have our these other services along with it. So the nutritional clinic was pre-existent, but it was functioning on its own. But when we started having these high-risk clinics, and when the surgeons also realized the importance of this, they started getting regular references from the joint clinic. So the moment patient's plan was made, the treatment plan was made, whether NACT followed by surgery or surgery alone, immediately the patients were referred to nutrition clinic before even they came to the high-risk JC consultation. So all patients started getting the regular clinics to nutritional clinic. The patients were referred also during chemotherapy from the GI and the head neck services. The select patients from gynae and uro also started getting, because there was a spillover effect from our thoracic and GI HRJC. And then the nutritional clinic started making the protocolized nutritional plan based on their various assessment tools like hand grip and calf circumstances, detailed patient's history, looking at the patient's weight loss, appetite score, and then the deficit was given in terms of commercial product supplements. Next slide, please. Like when these services improved, even the other services had to make improvements. So gradually they developed their own app, and they kept on revising the app based on the patients coming to them, and when they realized what are the patient's problems, they started improving on their own services. Next. So currently what they do is every patient and relative, when they go on the first visit, there's extensive counseling about the nutritional importance from the nutritional clinic, and then they're followed up based on the patient's underlying condition. So there's weekly for undernourished or non-compliant patients. There's regular after each chemo cycle, the patients are asked to visit, and the patients who are severely malnourished are followed up every 3 to 4 days. There's telephonic follow-up about the compliance, and if the patient is found to be non-compliant, the recounseling is done, and that gives around daily footfall of 180 patients to our nutritional clinic. Next slide. So then comes our physical rehabilitation clinic. So all patients plan for thoracic and GI and select genitourinary and gynae. Again, they go to the physical rehabilitation. In thoracic, the period that they get is more than 4 weeks, because these patients are referred during chemotherapy, as those patients require extensive respiratory physiotherapy. For the GI cases, the average day that they get is around 10 days. But now again, they looked at it. So catering to that much of a workload with the space crunch and people crunch, what our physiotherapy department came out with it, group rehab sessions. So currently they worked out with various number of the patients, and now they have started with the 5 patients with 1 relative each. They conduct these 5 sessions a day, where again in the beginning of the session there's counseling done. The importance of physical rehabilitation is told to them. They are taught the breathing exercises during that session, and then the patients are asked to do all those things at home. They are asked to walk every day for 20 to 30 minutes, and they are assessed every weekly. All thoracic patients and select other specialty group undergo 6-minute walk test before the rehab. And based on that, on the effort tolerance and their clinical evaluation, the patient has got severe sarcopenia. 6-minute walk test is less than 300. And if the effort tolerance is less than 1 flight, then these patients are given the individual session, and then they are asked to also given the resistance band, and they have been asked to walk. So this is they have given the individualized plan for these particular patients. Next slide. Next slide. So what do we lack currently? Of course, we lack the psycho-oncologists, but that is what we are trying to get away with doing. Extensive counseling by the nutritionists about the nutritional aspect, physiotherapists by the physical rehabilitation aspect, and by the clinicians when they come to our HRJC, we talk to them, we counsel them about the lifestyle changes and about the importance of having a good nutrition and good physiotherapy or the exercise. Next. So how we change our outcomes? So we looked at our outcomes before and after HRJC in the GI DMG. So as you can see, we started HRJC in 2015. So this is the result of your HRJC. All the patients, the outcome, the complication rate, Clavin-Dindo grade 3 to 5. And we looked at 3 hours data of HRJC in 21 to 23. These are only high-risk patients that we looked at. And if you look at complication rates, actually our complications rates in pancreas have come down, and rest of the rates have remained same. But remember, the HRJC is only high risk, that is not general. Pre-HRJC, what you are looking at, all high risk and the low risk cases. Next slide. And if you again look at it in the GI surgery, as our service started in 2015, our numbers started going up. So currently, if you compare with the 2013, now we are looking almost 3 times patients of the GI surgery volume has gone up. But if you look at the patient's mortality, the mortality has remained same in the numbers. So actually, our results have, our outcomes have improved drastically with all these measures that we have intervened. Next slide. Next slide, please. So how did we manage to add this extra service without asking for any other help from the administration? So first space, whichever was available. So we use our academic offices, surgeons' academic offices, OPDs, wherever the place was available. The manpower were only motivated colleagues and the staggered work. So wherever it was required, we worked in staggered workshops, and that's mainly what was done at our physiotherapy department. They are working now in the staggered work to cater for this increased workload. The time constraint we looked at, well, we had the surgical resident who will post, so we use a WhatsApp group of each specialty. The surgical resident will post patient details. Each member will go through the patient details from EMR at their own convenient time. In HRJC, the resident will come prepare the whole case history and the concerns, and he will present the case and outline the issues, so we did not waste much time over there. And then the counseling of patient and the relatives was done, which helped in shared decision making. And then the further follow-up of these patients was done in the surgical OPD. And then the consultant anesthesia was directly communicated, the OT anesthetist, by the surgical resident about the patient's compliance and the planning of the surgical plan. Next. So what more have we achieved? So now this is what we really did, what we expected from the rehabilitation, we achieved that. But we achieved more which we had not expected. One was there were a decreased number of footfall in anesthesia OPD because this back and forth movement of the patient decreased. So instead of patient visiting 4 or 5 consultants, the 4 and 5 consultants sat together and patient had to have only 1 visit. The number of joint studies and publications went up because now there was better cooperation and friendship between the group. It became a cohesive group. There was learning of anesthetics on surgical aspect because when we sat together we looked at the patient CT scans, MRI. So we understood what is the problem with the surgeons, what do we expect in each stage, where is the vascular involvement, what are the worries. So we started reading CT scan in a better way. There was involvement of primary anesthetists in the perioperative care. So the surgeon, if the patient in the ward didn't look good in the morning rounds, the surgeon will directly catch hold of the GI anesthetist and say that XYZ, please see this particular patient in the ward. I'm not liking his looks, or he is tachycardic, or I think his drain is high. So that led to early recognition and flagging of concerns. So the anesthetist will go up, evaluate the patient, and if required, will ship the patient early to the recovery room and the ICU. There was better working atmosphere. So these groups became so close. so that they started having dinner parties and they started attending the social events together. There was, as I showed you, there was increased volume without impacting outcome or rather improving the outcome. It also led to resident learning because the residents were present in these meetings. They were party to what the discussions that were happening between the consultants. So there was a better ERAS compliance that we found. The prehabilitation compliance also was good. The anemia correction. So we started seeing that more and more patients, irrespective of whether they were seen in HRJC or no, started coming who had already received either oral iron supplement or IV iron supplement when they came to us. More importantly, the outside practice, like when these residents left the Tata Memorial Hospital and went outside to establish their own practices, they carried this habit outside. And when we meet them now, they say that I have established ERAS guidelines in my where I'm working, or I'm working towards getting the prehabilitation done. And even the surgical consultants who have left the hospital and practicing outside have become great advocates of rehabilitation and ERAS even in the outside practice. So this is something that was a collateral advantage that we got after having this successful practice. Now, however, we still have got certain obstacles in India. First of all, we have got low awareness in healthcare providers and patients. We have got 60 to 90% of the patients have got inadequate health literacy, and that is a major issue that we are facing in India as of now. Next. We have got gaps in health literacy. So many patients still go for alternative medicine. And that's the reason we have got late presentation, and that leaves smaller window for intervention. Many times, even if the patient is deemed high risk, we do not have adequate time to prehabilitate the patient. There's obviously resource constraint, the human resource constraint, mainly in terms of physiotherapists and, as I said, psycho-oncologists. The facilities are not there. The healthcare infrastructure is poor. So currently, we have not added any infrastructure or the facility, just doing it in whatever space is available to us. But there are geographical issues. The major problem that we face currently, that Mumbai is a central hub. It's a financial capital of India. So majority of the patients travel for treatment. So currently around more than 70% of the patients that we have got in hospital travel from various parts of the India. So they stay in lodges, they stay on footpaths, they stay in hospital premises. So they really can't follow the nutritional guidelines or the physical rehabilitation or the pulmonary rehabilitation that they have been told about. Many of them take chemotherapy at other centers as they cannot stay in Mumbai. So whatever rehabilitation that we advocate, they may not get that facility in the places under one roof where they are taking it. They are called a day prior to surgery, so they may not have the physiotherapy or nutritionist or the gym available over there, so they may not come in optimum condition. And obviously, we have got weak multidisciplinary coordination, especially in the smaller institutes, which is a major part of the India treating these sort of patients. And again, there is time constraint and multitasking. Again, there is no social support. There is no community nursing, which is a good thing in Western countries where they have got community nursing. We do not have that concept in the major thing as yet. There is problem if we advocate the same patient with the home TPN, the patient who cannot, who is nutritionally very poor, there's problem in taking home TPN because there is no nursing support. We have got lots of system level hurdles as of now, the absence of national guidelines or mandates on prehabilitation. And I think it's mainly because we have got insufficient data from our trials to drive policy or adoption. We have got lack of reimbursement structures under national or private insurers. So the patient, when they come, what we have got national insurance, they will get everything only if they are treated in Tata Hospital. The moment patient goes out to his native place and he seeks some other treatment over there or going to physiotherapist, that will not be reimbursed under these schemes. There's significant, and that leads to significant out-of-pocket expenses, which many patients cannot afford. There is poor integration of prehabilitation within oncology care teams at many places. And maybe there is some amount of gender bias which is still existent, especially in the remote places in India. At patient level in India, we face other issues, the dietary preferences. A major chunk in Indian population is based on vegetarian diet, which is poor in the protein. So we have to counsel them, and some patients agree, some patients do not still change their diet preferences. There is travel fatigue and financial constraint. As I told you, many of the patients travel from the peripheries, which then they get fed up. There are misconceptions about exercise and diet before surgery. Many of them still feel that they should be taking good rest and should be eating a different diet before they are going for the surgery. There is literacy gap and misconceptions. There is a major digital divide. The interiors of India still are not that digital, and obviously they lack motivation. So one of the studies where we were looking at the patient's average, the physical activities before coming for the surgery, We gave them the digital watch and we asked them that every day they will take the photograph and send it to us. What we saw was median footsteps per day were around 1,500 for most of these patients. So they're not that physically active as of now. Next slide. So to conclude, feasibility, it's feasible to establish a prehabilitation program in India, especially in big institutes with the local modification. But I think what requires is a motivation from our side. India is becoming digital rapidly. The government of India's initiative is to have the digital India. Government wants to transform India into a digitally empowered society and knowledge economy, towards which the government has started taking steps. The internet, computers, and these services are introduced in schools on wider scale. This use of technology is rapidly advancing, and our younger generation, irrespective of location, is digitally literate. So it's possible to have these programs using the technology. And we have got successfully the community engagement of the grassroots workers. So we have got this ASHA program with which we have improved the maternal health. So we can utilize their services, develop those services to get this prehabilitation program across at more widespread level, and hopefully will improve the outcomes in the in our major surgeries. Thank you.
Thank you so much, Dr. Vijaya, for such a brilliant presentation. I really liked your story of how you started rehabilitation, expanded it, the challenges you faced, and the solutions that you brought in. I'm sure a lot of our attendees today have benefited from this talk. I now request our moderators to open the Q&A session. Over to you, Dr. Suwimon.
Hi, thank you so much, Vipar. And there are many questions in the Q&A session, and some questions are in the chat box. I will start with Dr. Nabil first. Dr. Nabil, and can you remind us again between personalized approach and protocol approach?
Yeah, well, thank you. So this is exactly what we mean by trying to define what are the patient goals in the recovery. And that speaks pretty much for the mindset of just going away from the mindset of being a technician, if you would say. So as a person who's pretty much a big fan of regional anesthesia and big fan of blocks, I always encourage our residents and our trainees to think about regional anesthesia as a tool. You are first and foremost, you are a physician, you are a perioperative physician. So really, how can we use that to help your patients? Now, a patient comes in so many different flavors, shapes, and sizes. Some of them, if you think about the bell curve, I mean, this is probably a good analogy. The bell curve, about 75% to 80% of our patients are going to fit within the protocolized medicine. Our ERAS, when it's almost dictated as 1, 2, 3, the almost a cookie cutter, protocol. But you're going to have outliers on both sides of the curve, right? You're going to have people who are very, very sensitive to all the analgesics, and you have people who are going to be resistant, people who are going to need more opioids, people who are going to need extended duration of blocks. Maybe just we're going to come, if I'm going to put the two talks together, I'm going to use Dr. Meier's talk about AI. Is there a word in the future if we fantasize a little bit about just defining some patients to identify some variables in this patient, I need to come at them with all the powers and all the tools I have. This is a patient I'm going to put a catheter in. I'm going to keep that catheter for 3 days. And I'm going to just give them high dose of opioids because I know, based on the information, that probably they are not going to do well with just the protocolized medicine. Maybe this is in the future, but actually I feel the future is now.
Thank you so much.
So we have some questions.
Okay. Dr. Lugazia, continue, please.
Yes, so we had some questions in the chat, 2 of them. Let's clear those. One is from Shavan to Prof. Jen. You wanted to know your take on AI as an anesthesiologist, the effect on AI jobs globally. Due to advancement in monitoring, let's say, will AI affect workforce reduction of anesthesia doctors in a hospital by reducing direct monitoring need? And the second one goes to Dr. Vijay. Do you have criteria for when to refer surgical patients to psychologists? I thought we should clear those from the chat and then go straight to those that were posted in the Q&A section. Thank you. Professor James Meier, can you start with yours?
Yeah, so if I understood the question right, it is whether we can be substituted by AI as anesthesiologists, and there is, of course, the fear that this might be possible. I'm not too sure whether this will really happen. There are several aspects to that. I think the first aspect is, and this is something this has been investigated by psychologists, that patients really want their doctors, patients want other humans that are empathic. Of course, large language models have been shown that they also have the possibility to be very empathic, and that as a consequence, sometimes even patients with psychiatric diseases like to talk to these large language models. But I think there will be always this human touch that is needed for the treatment of patients and that is needed on a daily clinical basis. However, what I'm also sure is that in some years, the doctors that do not use the methods of AI, that do not deal with the things that will come up, they will fall behind. And then in the end, they will have a real problem. So the ones that use AI, they might be the ones that are on the forefront. But it's difficult to judge right now because 2 years ago, no one believed that these AIs that can do coding, that can program, are as powerful as they are. And there are now many of these professional companies that really kick out a lot of personnel due to the fact that the AI is much better than any of the human coders. So difficult to judge, but specifically in medicine, I think there always has to be this human touch, and patients will appreciate that.
Okay. Dr. Vijay, next.
Yes, so we do not have a specific criteria to refer the patient to psych-oncologist. One is because we have got only one psych-oncologist for the whole hospital, and she's really inundated with the workload that she's got. So those patients who are overtly very anxious or very depressed, and those patients, in spite of our counseling, are non-compliant with the treatment and say that they've got lack of sleep. So many patients come with that they can't sleep, they're anxious, they've got fragmented sleep, they get morning, when they get up, they get headache. The signs and symptoms suggestive of high anxiety level, those are the patients we refer to psycho-oncologist. But as of now, we do not have very, very stringent criteria or the objective criteria based on which we will refer them. So this is more of subjective.
Okay, for the next question for Dr. Vijaya again. And what is the optimal time period that can be allotted for rehabilitation in patients scheduled for cancer surgery without compromising on disease progression?
So the first dictum is rehabilitation should not compromise on disease progression. So whatever window that you have got, your rehabilitation will happen only in that window. So again, the way our program has gone and everyone being aware, quite a few significant number of our patients are referred for rehabilitation when they are receiving NACT, the neoadjuvant chemotherapy. So if you look, the current cancer management, the neoadjuvant chemotherapy has become a norm. Most of the patients receive NACT, which gives you more than 4 weeks. So during the NACT, the patients are referred, patient gets adequate time. What is said now, the newer studies are saying that whatever period you get, it may be so ideal period is said 2 weeks and more. But even if you get week and 10 days, you can still do something and you can still improve patient's health. So do not say that. So we should not refuse rehabilitation because I do not have enough window. Whatever period you get, you should utilize it to get the rehabilitation done. But as I was saying, if you have got, if your surgeon is aware, if there are on board with you, they can get rehabilitation. You can get enough time for rehabilitation.
Okay, thank you.
Well, The next goes to Professor Jones again. What would be your advice to young consultants regarding resident supervision about the use of AI in personal clinical judgment practice?
Keep up to date with the ideas. So it's always important to follow this. And to be very honest, the development of these AI tools is really progressing like crazy. If you read now something about a large language model, in 2 months, this is already new. You just can try to keep up to date. What is really useful and what is even more powerful than I thought are resources, and it's as easy as it sounds on YouTube. There are so many things that are explained flawlessly how these concepts work, so that you have to try to follow these videos. There are so many public channels that explain the main ideas of that, so that I would think this, in my opinion, is the easiest, best accessible, and most useful way to be taught.
I had a very interesting question to Dr. Jens. With the use of AI coming into our practice, do you think that we will start using our brain less and the processing capacity of our brain could reduce?
This is a really good question, because we have the same problem in similar fields. My most favorite example is when I was a young guy and I had long hair and I became a young doctor and I was enthusiastic. I bought myself a Littmann-free M stethoscope. You probably know them, this expensive one with 2 tubes, and I was so proud of it, and I was wearing it around my neck and walking around. Now I'm a real doctor. And my young people today, does anyone own a stethoscope? No. What are they doing? They take out the ultrasound, put it on, and they know more about the patients I ever have known in advance. So times change, and are they more stupid, or are they not as good because they cannot listen and they need ultrasound? No, they have different skills. So I think we will probably not use the same skills. I think we will probably use different skills. Probably our focus will be shifted, but in the end, we have to go with the flow, in my opinion.
Thank you. So wonderfully answered. I can still see a lot of questions coming in, but I really have to apologize to our attendees that we are already 7 minutes past the closure time. Please send us these questions and we'll try and answer them to you if you email them to us. And with a heavy heart, yes, yet with a pleasant mind, I close this webinar today, and the wisdom, the viewpoints that the speakers have given us will keep resonating with us. I hope that this webinar has inspired us to increase our involvement, not just in learning procedures and techniques, but in creating patient care pathways. Stay tuned for more activities under the annual theme. And as Dr. Catalina mentioned earlier, these are the ways that you can get involved with the annual theme and us. The member societies, specialty groups, and individuals could explore the theme within their fields. They could organize webinars, hold discussion forums, write blogs, opinion pieces for their society websites and journals. Please follow us on social media. Join the 2026 annual theme campaign. Tell us your stories. Remember to hashtag with you every step. Let us know and we'll share it further. For ideas, comments, please write to us on comms@wfsahq.org. I look forward to meet you in person at the World Congress in Marrakesh, April. In case you're unable to travel, you can choose the on-demand registration to stay abreast with the academic deliberations. For more details, please visit WCA website. Thank you for your time and attention. goodbye, and stay safe till we meet again. A big thank you to our esteemed speakers, moderators for such a wonderful webinar. Goodbye.
Thank you.
Thank you.
Thank
Thank you.
Bye-bye.
Thank you. Goodbye.